health plans can participate. Thank you for joining us. My name is Miranda Woolston, and I'm the Senior Manager of Communications at CAQH. I'll be your moderator for today's presentation. During this session, your phones will be muted. However, if you have a question, you may ask it at any time using the online question panel. The Q&A panel is on the right-hand side of the GoToWebinar desktop. We will address questions at the end of the presentation. Today's presentation will be posted online on the caqh.org website. It will be available within 24 hours. I'd now like to hand over the presentation to Jeff Lemieux, CAQH's Director of Research, to introduce our speakers.
Thank you, Miranda. Today's session is about the CAQH Index and how health plans can participate. And to help us with that discussion, we have two experts who have been working with the Index and are members of our Index Advisory Council. First is Paul Keyes from Cigna. Paul's product manager for Cigna National Provider e-Services. He's been responsible for Cigna's provider connectivity strategy since 1992. He's worked for Cigna for 31 years in management roles in operations, compliance, EDI, and EDI vendor strategy and management, and has extensive industry work group experience, including being board member of WEDI, participating with CAQH's core operating rule development project, and serving as the Cigna lead for the CAQH EFT project. Our other panelists today will be Tab Harris of Florida Blue. Tab is the Director of Provider Connectivity Solutions and EDI Operations at Florida Blue and is accountable for all provider e-capabilities, including HIPAA and HL7 transactions, in addition to portal-based capabilities. Florida Blue has been recognized as an industry leader and a model for gateway management and mandate implementations. Tab has been with Florida Blue for has 24 years of experience, commercial and Medicare healthcare experience, and it's associated with Florida Blue and its associated organization, First Coast Service Options, and has worked for the last 16 years in electronic data interchange space. He's a frequent attendee and presenter at conferences, a voting member of HIMSS, WEDI, X12, and other industry tech groups. And as for myself, I'm the Director of Research, and I've been coordinating work on the CAQH Index now for CAQH for this year and last. So about today's discussion, what I'd like to do is first go through some background information on the CAQH Index, where we are and how we got here. We'll talk a little bit about our plans for the 2015 index, and then we'll turn it over to questions and answers with myself and especially with Paul and Tab. We have some questions that have already come in, and I'll start by asking those to Paul and Tab in turn, and then we will open it up as Miranda explained to your questions live. And please feel free to start asking questions, and we'll tabulate those and read them back and answer them in the course of the presentation. So what is CAQH? Most of you may know this if you've attended our past webinars on the index or other subjects, but CAQH is a nonprofit alliance. It creates shared initiatives intended to streamline the business of healthcare. That usually involves collaborations with healthcare plans and providers to deliver value to all the stakeholders. In particular, CAQH has some unique and individual solutions, including COB Smart, which helps streamline coordination of benefits processes, CAQH ProView, which eases provider data collection and sharing, the Enroll Hub system, which is our simplified provider solution for electronic payments and remittance advice, and CAQH Core, which develops and helps implement federally mandated operating rules for electronic standardized transactions. And if you have questions about these other facets of CAQH, you can also feel free to put them in the chat box or to email them to me, and I will forward those to the appropriate expert who can help get back to you. Today's discussion will be about the CAQH Index. So what is the CAQH Index? It's intended to track the progress of this transition from manual to electronic administrative transactions. We collect a very large data set on transactions from healthcare plans, and also we collect information from healthcare providers. The health plan information includes information from health plans representing over 112 million covered lives. We asked plans to enumerate or count up their numbers of industry standardized HIPAA electronic transactions as well as manual transactions of various types, such as phone transactions, fax, mail, web portal, and those sorts of things. We measure adoption rates, and then we attempt to estimate the cost savings and that's associated with the switch to electronic transactions, using data on cost per transaction for both health plans and healthcare providers. We do not measure what we call sub-adoption criteria, such as the adoption of operating rules or the data content of transactions. And as I hinted at the start, our process is guided by people like Paul and Tab, who are members of our advisory council, experts in these sorts of claim-related and business transactions and processes. We have members from health plans and facilities and providers of that advisory council who help us shape our agenda. So now to the data itself. I'll go through this in a fairly quick way because many of you may have attended our prior webinars that explained this year's results. The data, as I mentioned, is mostly from health plans on the commercially insured population, but it also includes managed Medicaid and managed Medicare. This last year, the report that we just put out had breakouts for Medicare Advantage and then large multi-state commercial plans versus Blue Cross Blue Shield single state plans. And for 2015, we're hoping to add dental health plans as well as Medicaid HMO as separate breakouts for benchmarking. As I mentioned, the health plans contribute a very large data aggregation, including about 112 million enrollees this last year and about 4 billion transactions. On the healthcare provider side, we are assisted by consultants at NORC, National Opinion Research at the University of Chicago, and also Milliman Inc. For the collection of data from providers. And we won't be talking about the data collection process from providers today. Today we're just going to be talking about health plans. But we're planning a webinar for healthcare providers who would like to partner with us and provide data for the index project and then receive benchmarks back in return. And the date for that webinar is expected to be June 10th, and we'll have some providers on who have participated in the past, and we'll be, look for an email from us about a week or so from now with the details of that webinar if you and your partners might be interested in that provider side data process. This year we're calling it the 2015 index. The data will be for the full calendar year 2014, January through December of last year. Last year's report, which we called the 2014 index, contained full year data for January to December 2013. And we now have data, we will have data this year for the third year in a row, which allows us to do a trend analysis in the benchmarks. The report that we just released in March, the 2014 report, I've shown this slide, just shows a little bit of a picture of the cover page. But that, as I mentioned, contains data for calendar year 2013, and the following transactions were analyzed in detail in that report. Claim submission, eligibility and benefit verification, prior authorization, claim status inquiries, claim payment, and remittance advice. We also, those were transactions that we've now measured 2 years in a row. This year will be the third. We also added some new measures last year. We have preliminary initial data from the 2014 index on claim attachments and on prior authorization attachments. And we're adding additional measures this year on coordination of benefits claims and referral certification transactions. We're breaking that out in a little bit more detail than we have in the past. And then we're adding some non-provider transactions this year, such as the employer enrollment, disenrollment transaction and the employer premium payment transaction. Now to turn to the basic results from last year, we estimated that health plans on just the 6 main transactions that we've now been tracking for 2 years could save over $1 billion from continuing the transition from manual to electronic transactions on those particular items. Claim submission and claim status inquiries in particular were areas where health plans, and as well as eligibility and benefit verification, are areas where health plans could save a lot more money from reducing the number of manual transactions and increasing the electronic automated ones. The estimated savings were even higher, dramatically higher on the healthcare provider side, especially for remittance advice and eligibility and benefit verification transactions, totaling up to over $7 billion in additional industry savings. And the sum total of both health plan and provider savings, we estimate for the second year in a row, remains a little over $8 billion. And where do these estimates come from? 2 key components, really. The first component is our estimates of how much the transactions cost, manual versus electronic. I won't go through this slide in detail. There's a lot of information here. The report explains where the data comes from and how they're estimated. But on average, we're estimating that for health plans, the cost per manual transactions is about $2 versus 5 to 10 cents per transaction for electronic transactions. And for healthcare providers, the manual cost is as much as $5 per transaction versus $1 or $1.50 for electronic transactions. Now, when we look at the gap between the costs of manual versus electronic transactions, then we can apply that to our estimates of how many of these transactions are remaining manual. And the process gets a little bit more complex at this point because we measure transactions in a variety of ways. On the far right side of this slide is our estimate of the overall percentage of electronic transactions used by health plans and providers combined. But we also break that down into health plans versus providers. For health plans, we view certain types of transactions as automated that may not be considered automated for healthcare providers. A good example of that is an interactive voice recognition system or a provider web portal where the provider has to type in data manually, but that can be automated on the plan side. So we parse that out. And as you can see from this graph, there's a wide range of adoption of transactions that are fully automated, especially on the healthcare provider side, ranging from as low as 7% for prior authorization to a high of 92% for claim submission. And the following charts illustrate that in addition to the overall percentages of adoption of electronic transactions, and in this chart it's just the fully automated HIPAA standardized ones. Even among health plans, there are wide ranges of adoption. For example, in this chart that you're looking at, health plans using the fully automated 835 remittance advice transaction, some plans had rates of using that transaction that were less than 20%, and others had rates that were over 70%. Similarly, on the next slide, you can see that the ranges of adoption for automated transactions on prior authorization, eligibility and benefit verification, and claim status range widely. For example, we had plans reporting data, some plans that had very little or zero adoption on claim status, and others that were close to 100%. So you can see that the industry as a whole has plenty of room to grow on electronic transactions. Now, as a health plan, how do you provide data? The data request comes in the form of a spreadsheet that looks something like this. This is just a small panel of it, but this is the basics. We ask for total counts of transactions by type for the main subdivisions of your company. Some companies can only report commercial. Others are only in the Medicare Advantage or Medicaid HMO business. We're asking separately for dental this year. Even within dental, there may be subcategories, and the chart expands to the right to allow for example, dental Medicare and Medicare Advantage or dental Medicaid HMO. So basically, what we're asking for is, how many claims were submitted electronically versus manually by these types, or for example, further down in the second bank, how many eligibility and benefit verification transactions were done by telephone, by fax, interactive voice, web portal, or the HIPAA 270. And then there will be a bank of data request for each of the transactions that we're looking at, the main 6 ones and then the new ones that we're in the process of adding in. So that's how we compute the adoption rates. We calculate aggregated numbers. You put in the numbers from your company for each of those items. Then we also have worksheets that we provide for estimating cost per transaction. Some plans have different ways of estimating this, and we don't prescribe one way or another. As a matter of fact, the worksheet has different types of worksheets for companies that might have different types of data. But in order to estimate cost per transaction, it's typical to think of the number of work hours going into handling these transactions, either manual or electronic, the labor costs per hour, and the overhead rates. And by then applying the total number of transactions handled in that fashion, we can get an average cost per transaction. Finally, I'd like to turn, before we start our panel discussion, over to some slides that give you an indication of the benchmark reports that companies get back as participants in the index. The benchmark reports contain 2 types. One are the slides, and another is a detailed table that contains even more detailed information. I'm just going to share some pictures of the slides. And in these slides, I haven't obviously identified a given plan. That's just called Plan A. We don't show individual company information in the index. We only put out aggregated information. But we provide back to your company how your company stacks up relative to the averages of other companies. This particular slide gives you an idea. As I mentioned, we had over 112 million total enrollees. And we also collected data separately for multi-state plans and single-state plans, so that would give you an idea how your plan compares in size. On the next slide, we provide some basic benchmarks, claims per member, prior authorizations per claim, those sorts of benchmarks to see where your company would fit in. For companies that have provided data for more than 1 year, we can do year-on-year averages and then compare that to other companies that have provided data for more than 1 year. And so show how the growth of certain types of transactions compares with the overall growth of those same transactions. Some additional information, probably this is the key slide that most companies want to look at, is how do my adoption rates for the fully electronic transactions compare with other benchmarks. Other slides that are very interesting to plans are how do my costs compare to benchmarks, and this slide shows the averages for cost per transaction that can be shown up against how their companies are estimating that. And then the final slides in the slide deck just give an illustration of the granularity of the detailed tables that we put back so that you can go in and look at percentages down to the fax and web portal and IPR sorts of transaction levels for each of the main items, claim submission, claim payment, eligibility and benefit, and so on. So moving ahead to what can we do to help you get your company interested in this, we have a flyer that's available on our website, which can be useful for passing information about the basics of participating around the company and building interest. The 2014 report, as I mentioned before, is already available, as is the reporting guide, which is the more detailed instructions that go along with the reporting. The next slide shows the categories. Basically, what we've been told by participating plans is that the spreadsheet where you input data is fairly self-explanatory, and you can basically get the information from that. But we also have a detailed reporting standards and data submission guide that we can use to clarify some of the nuances. And the Advisory Council and its subgroup of responding companies who work on the technical details of the specification have spent a lot of time going through detailed questions of how to make sure that the data come back from each company in the same way so that we have accurate benchmarks. And there are a host of examples in that, and there's a link, as you can see on the top of the slide here, that you can click on to get a feel for how the data submission guide reads and the sorts of things that are involved. So at this point, what I'd like to do is turn it back over to Miranda to remind us on how to enter questions. And then we'll start with the panelists, with Tab and with Paul, with the questions that we've already got, and then we'll answer the questions that you're submitting contemporaneously as they come in.
Thank you, Jeff. We'd again like to invite attendees to ask questions by typing your question into the Q&A panel on the right-hand side of the GoToWebinar desktop. Jeff, will you get us started with our panelists?
Okay, so of the questions that we've got so far, there's a couple of categories that are coming out. We have a couple of basic general questions, and I'll try and answer those, and then I'll turn to Paul and to Tab. So just a couple basics. Does the index plan to include any new measurements this year? Yes, we have a slide on that. It's back in the middle of the deck, but as I mentioned, we have some additional details that we're going out this year. We want to continue with the attachment transactions, and we're adding some of the employer transactions for premium payments and enrollment, disenrollment, and we're also breaking out referral certification and coordination of benefits claims this year. If I contribute, is my data going to be shared with others? No. The data from each individual company is confidential. We only report aggregated data in the benchmarks. And that's one of the reasons why we're trying to get a wider span of companies reporting in the dental and the Medicaid HMO space so that we have the ability to provide separate benchmarks in those spaces so there's enough plans in there so that we can get a good aggregation. Last year we had some companies reporting dental and Medicaid HMO, but not enough for a full aggregation. Let's see, one more basic. Oh, how does the index develop its methodology? The advisory council plays a key role, and data contributors are welcome to be part of that process, and I'll also allow Tab and Paul to talk about that. How many plans and providers participated in the 2014 CAQH Index? On the plan side, there were, I guess I should say, most of the large multi-state commercial plans participated. That was sort of the core of the participation. Last year, we concentrated on expanding the number of health plans, particularly among the single-state Blue Cross and Blue Shield plans. And we had several conference calls among Blue Cross and Blue Shield plans to try and orient them to the process and see if we could generate interest, and that was very successful. And Tab Harris actually was a very key part of those, and we'll probably attempt to do that sort of thing this year. We'd like to get more smaller plans in, but we don't have enough of them yet to provide a breakout benchmark for smaller or regional health plans or HMOs. And with that, let's see, let me turn to the questions that have come in for the participants themselves. And let me start with Paul. As I mentioned, Paul's product manager for e-services for Cigna. And Paul, the question comes in, how many years has Cigna been participating?
Oh, let's see. This will be the third year that we're participating. And, how we've participated or what we've been able to contribute has, varied a little bit over the course of 3 years. So we, supplied commercial data the first time around. The last year we were able to add separately our Medicare Advantage data. And then this year, as Jeff mentioned earlier, dental will be broken out separately and we'll be contributing to that.
Let's see, how long, this is an excellent question on the level of effort. How long does it take Cigna to develop the data between when you receive the data request and then submit?
Yeah, and it depends on which category of data. Because some of the data, and I assume for some of the others on the call that this is also true, is that for some of the data that CAQH is looking for, that you and we track as a normal course of doing business. So, for example, the number of claims that come in the door that are institutional, professional, electronic versus paper, or payments that go out the door that were electronic versus paper checks, things like that. So, for stuff that is part of the normal course of business, the reporting is, done by January 15th for the prior year and ready to go. There's other data that's a little bit harder to get. Takes more time. It really depends on which tables it's in and who has access and who owns them and that kind of stuff. And then there's other data that may not be tracked at all, and then we have to put in requests to try to make that happen. So, and those things take varying lengths of time. So it really depends on the data category.
I guess one of the things I would throw in just to amplify what Paul's saying is that there may be some transactions that companies don't have data on and can't yet by the time, but that doesn't preclude participation. We've had several participants who were able to answer 3 or 4 of the questions, but not the 5th or the 6th, and that's still very useful to the overall process. Let's see. This is sort of a follow-on to how you just responded, but do you have to work with other parts of the organization, and how does that work out when you're coordinating the data request for a large company?
Yeah, I definitely have to work with other parts. I mean, there's certain things that obviously I own myself and have access to, but then there's other things like the Medicare Advantage business, which is our Health Springs subsidiary that's run completely separately from the commercial business. So I have to reach out to those people and get the data from the appropriate people within that organization. So yeah, and then again, like for data that I don't own within Cigna, I've got to identify the owners, or we have an internal process to open a ticket to our business intelligence area to make requests. So that's all really good. It depends on how your own internal organization is set up and organized, and who's kind of responsible for different types of data reporting and analysis.
So here's the question that I can modify a little bit. I mean, how does Cigna use the data, and do you push the index data back out to those units that are helping to provide it to you as the coordinator of the index data collection process?
Yeah, we use the data for 2 things. One is the benchmarking that Jeff talked about earlier, and yes, we do share the CAQH Index report with the areas that we collected data from, and also with other people in Cigna who are responsible either for the transactions and provider relationships and things like that. So that's kind of the case there. And what was the second part of the question, Jeff? I just flipped out on that.
Oh, do you just the internal use of the data?
Yeah, actually, I just forgot where I was going with that. The other piece that's important to us is the provider cost information, which isn't something we supply, the providers do, but it's a very valuable part of the index to us, because we take that and add that information into our electronic transaction promotional materials that we share with the provider community as we try to get the ones who have not adopted certain electronic transactions to get them to do so.
Thanks, Paul. I have some questions here from Florida Blue. For Tab, how did Florida Blue first learn of the EDI of the index report?
Yeah, we actually I was pointed to it from Devin Jopp. He's the president and CEO of Weedy. Our transactions had grown significantly in 2014, and we were, just from a cost factor, we were trying to find a white paper or some type of national standard for HIPAA transactional cost. We work well with our vendor, but we just kind of wanted, but we wanted to see if there was anything out there, and he pointed that to me. And actually, I immediately reached out to CAQH, and Jeff, you may remember, I started asking a whole bunch of clarifying questions. And I believe CAQH was right in the middle at that time last year of finalizing the report, and that's when you had asked if Florida Blue would not mind contributing, and I went into FastPath mode. So that's how we learned about it and jumped into FastPath mode. And again, I appreciate the council and CAQH for allowing us to contribute, and we sure did learn a lot from that.
Yeah, that's kind of a lead into the next question was, did you learn anything about your own efficiency after contributing to the report? In other words, did the data collection process cause you to learn things that maybe you didn't know before?
Yeah, and actually to step back a little bit, like I said, that the council and the CAQH was already in the middle of it. You guys had allowed me to join in on a few calls to learn a little bit before we made commitment. And I was actually learning a lot from basically just how do you define true EDI or true interoperability. I mean, is a scanned PDF in an email, is that considered electronic? I would say there's a lot of business insurers that would say yes. And I would say probably within our own walls, I was finding out from our business owners that, there's a lot of things that come out of the woodwork when you start digging, when you kind of have always labeled it as electronic, but really is it, truly, electronic. So that's one of the things that we definitely learned. And I also agree with Paul, the provider data and the provider cost was very valuable.
This next one looks like it's a little bit redundant. Let me see here. Same question as for Paul about the level of commitment and hours and effort to contribute the data to give folks an understanding of how much of a lift this is.
Yeah, and I think Paul said they had contributed 3 years, and as a national, we are a single state blue plan. We still have quite a bit of electronic traffic going through, as well as our manual transactions. It took a little bit, but we were in a learning mode as a first-time contributor as well, I would say, and also learning a lot from the council and from CAQH. I had 3 resources of my EDI team working with the business units that do all the manual processes over a 2-month period, and it was about 50 man-hours. So that's a little bit of time commitment. But in my opinion, I worked it with leadership to ask for that commitment and ask for the partnership with all the areas, because we were, like Paul said as well, we had to ask other areas for lots of data. So some of it was readily available. Other data was not that easy to get to. So about 50 man-hours for Florida Blue specifically. We believe already for 15 that we're starting on, it'll be a little bit less time.
Mm-hmm. The question is, what were the hardest measures for Florida Blue?
I think the hardest, I wouldn't really call it hardest. I think it's basically getting down to the granularity. We also found opportunities where we can better report our product lines or our lines of business, such as the Medicare, the PPO versus HMO, things like that. That was I would call it the hardest part, or the most difficult. And I believe you already covered this, but some things that we couldn't answer, we either lumped it as a whole or we just could not answer those questions, which I was very thankful that CAQH could do that and still use what we could contribute.
At this point, Miranda, are there any other live questions coming in that you'd like to ask our panelists?
There are. So we've had a few people question where they can find today's presentation, and we will be posting today's presentation on the caqh.org website. It will go up within the next 24 hours after this session ends. Another question we received is there a fee for participating?
No, it's absolutely free. Like Paul and Tab mentioned, I mean, this is basically a process of submitting data for the betterment of industry knowledge of where we are, but it also can feed back into helpful business information for the companies providing the information. The overall CAQH is a nonprofit. We put the results of the report up on the website. It's free and available for anybody to get. The detailed breakdowns just go back to the responding companies that show how they stack up.
Okay, another question we've had is asking you to look into your crystal ball. The index data that we put out in the 2014 CAQH Index is from the 2013 calendar year. Do you anticipate significant increases in transactions as a result of health plan promotion of electronic transactions as a result of administrative simplification?
I'll punt that to Paul and Tab. That's a great question.
Yeah, I'll
Paul,
speak.
do I anticipate significant increases? It really depends on the transaction. I anticipate increases in electronic activity over manual in all transactions, but in terms of significance, I mean, there's not that much left to go with the claim transaction, with the bulk of the industry at 92% electronic. With the remaining claims, actually, I did some analysis myself on that stuff and found that half of our paper claims are either COB or from providers who only submit paper to us, the 100% submitters, and the other half is paper from electronic providers. So you've got, that's less significant in terms of what's left to attack. And then if you look at the payment side of the house, depending on the payer, but the percent of electronic payments range, I think, in the industry anywhere by payer between 10% and 75 or 80%. So some of us have a long way to go with enrolling providers for electronic funds transfer. And so there's room for significant gain there, and I think that will happen over next year and the next few years as more providers seem to be, at least from our perspective and what we're learning, interested in jumping on board with that. And also just to take it aside and put in a plug for the CAQH Enroll Hub, which enables providers to enroll with EFT with multiple payers who are participating in that, is helping move that along.
Yeah, and from Florida Blue's perspective, I would tack on, I absolutely agree with the EFT and also agree that there's not much you can squeeze out of the claims. What I will speak from just a Florida Blue perspective or any other plan that may be shifting their platforms, enrollment or their authorization. We did move to a new care platform, utilization management, and our pre-certifications and authorizations. So that will increase from our plan for us. So anybody else that may have not been able to do a real-time authorization, I see that there are, from what we see and who we speak to, there are a lot of plans moving to that and a lot of companies selling that type of activity. So hopefully the authorizations will increase. And I definitely agree with the EFT.
Another question, do you have to supply data for all data points? Some we do not capture, could not supply without major effort.
Yeah, we talked about this a little bit just a few seconds ago, and the answer is no. Some plans are able to break out by their business categories. Some plans only return a total. That's fine. Some plans can respond in all of the categories. Some plans can't. That's fine too. And then it just becomes a learning process. I'll say that, basically, even though the data request goes out and there's an instruction guide, we spend a lot of time going back and forth with companies as they're, estimating the data and collecting the data. And so it's often an iterative process that goes back and forth where a company will submit, and I can compare that against the preliminary benchmarks that other companies have sent in the aggregate, or I can compare it against last year's results. And we can go back and forth and see if we've, made sure we've got a complete data set. Like, to give you an example, some companies have different platforms or multiple platforms, and we're trying to get data for the whole company for the whole year. And if a data concept such as claims submitted looks really low for the amount of total enrollment the company has, one of my questions is going to be, now you're getting fewer claims per enrollee than most plans. Are you sure you got all your units in? Or, or should we just cut down the enrollment to that sector of your company that you're able to get data from to make sure we've got the right proportions? And so that sort of thing happens a lot, and it plays out over time. And I'll also mention the timeline. You haven't asked it, but I'll answer it anyway. We put the data requests out now, and we're working with health plans, new and we call them experienced, to start to get the data in for this year. We expect the data collection process to last through the spring and into the summer. Most of the plans that have done this once or twice, they're getting good at it, and we expect their data to start rolling in next month. But other plans, it will take more time. We're hoping to get it all wrapped up together toward midsummer, the end of July and August, and at that point to put it all together and redo the report as soon as we possibly can.
A question has come in towards our panelists. How did you get others in your organization to support participation?
This is Tab from Florida Blue. I'll speak from us. Last year, with the healthcare reform and our exchange coming into play, we had also new leadership, so we were looking at every piece of administrative costs very, very close. I'm sure a lot of everybody on the phone was, but we really were scrutinized every manual process and our electronic costs, along with the vendors that we paid for those to help us with those solutions. So that is how we started looking at it and trying to identify what is a standard out there and how we can help our providers as well.
Yeah, this is Paul, and kind of what I did was kind of like what Jeff already did as part of the presentation is I kind of reviewed the importance of data collection and the output with the people who needed to help me out, and gained their commitment, and then I followed up with them to death until I got what I needed.
The next question we have is, are health plans able to contribute data without being identified?
Yes, absolutely. Basically what would happen is, basically we don't specifically identify which plans contributed. However, obviously you have Tab on the phone, you have Paul on the phone, so you know that their companies contributed, and they don't have a problem with that. But if your company did not want to be identified, that's fine. We would probably, we would like to have your input on the advisory council, but we wouldn't necessarily have to put a name up on the advisory council that would indicate that your company was part of the process. If you would rather do it, completely confidentially the first year.
The other question we have is, were there any resources necessary that you did not anticipate?
No, this is Paul, and the answer to that is no, but I've been around a long time, so I have a pretty good idea what to anticipate and who to go after.
Yeah, and for us being new, no, I was open to anything. Florida Blue was. And if you don't mind, I'd add on to Jeff, your last statement there. We, of course, I went to our legal, and they had no issues since the data was being aggregated like that, and had no issue with Florida Blue's name being on there.
And I think after hearing all this, for our panelists, are there tips that you would give to other health plans that are considering participation now that you've been through this once? Are there things that you would share to attendees on this webinar that might be helpful to them?
So, Paul, I'll speak from a first-year contributor. I found the council, like Paul and some of the others on the council, very helpful as well, CAQH helpful. So I was a little concerned not knowing the process and getting in there, but it was easily that my concerns were quickly relieved, and found that there was more benefit from this little bit of work for us to contribute, and then to see the output. And of course, like when I saw the first report that from the previous year, totally made sense to get in there, and for us payers who can and have time and have the reporting capability contribute, because it helps us as in our industry, see the cost of that and how can we reduce it.
Yep, and this is Paul, and I agree with Tab's comments and have found the council participation to be very valuable to us. So I'm good with all that, and I think, I think I'll end it there, because I was trying to figure, Tab, is there something there that you didn't capture, but I think pretty much you did, so I'll stop.
Great. There's a couple of additional questions that have come in that are specific to our other initiatives, so we'll follow up with those folks offline. And Jeff, I'll just turn it back to you for a minute.
Okay, if there's no other questions, I just wanted to call your attention to these links on the screen. As I said, the past reports and all the specifications for health plans are available at caqh.org. And my contact information is there at the bottom. And my contact information is also on the website. So feel free to contact me if you're interested or if you'd like more information. And if there's no other questions coming in, let's all just virtually thank Tab and Paul for joining us today, and thank you for your attendance, and look forward to working with you.
Thank you all. This concludes today's webinar, and on behalf of CAQH, thank you again for attending our presentation.